will give us a talk about comparing the late outcomes of Senning and mustard patients versus atrial switch patients. Please, Katja.
Thank you, Lothar, Björn, Professor Berger. I will tell you something about late outcome and late complications, and the title is Senning versus switch, but I also talk about mustard patients, so Senning here is a synonym for the atrial switch patients. Patients have grown older. Also, the arterial switch patients now have reached adulthood, so that there are a lot of studies in the last years who have concentrated on long-term outcome and late outcome. The first concerning atrial switch, both types of operation, then the next three ones concerning arterial switch operation, and the last three comparing the two types of operation. And as you see here is a large amount of patients, about 800 in this Toronto study and also 800 in the Munich study. Atrial switch we heard a lot of yesterday concerning survival, which is for in the long-term outcome bad, as a relevant percentage of patients die. Here more bad for the mustard patients, but as you see here, this has been the earlier years of operation. Perhaps this is also an important fact due to the survival. What we see here is, concerning outcome, that the survival without reoperation or heart failure or arrhythmia is even more bad than for just survival. For the simple, it's here, for the complex, there. So then we see age at operation is also of concern. Early repairs predictive of a better functional result, what we see here, and also concerning the late complications. A lot of problems are concerning rhythm and arrhythmia, so there's no difference between the mustard and Senning patients, and what we see is a progressive decrease in sinus rhythm, a progressive increase in supraventricular tachyarrhythmia, which are requiring a therapy, but the loss of sinus rhythm and the presence of arrhythmia in ECG or Holter ECG does not identify the high-risk patients concerning survival or late death, but there's a significant relevance of atrial flutter, which then leads by rapid response of the ventricle to late sudden death. Yeah, factors concerning mortality. There are the patients with a severe tricuspid regurgitation. The NYHA class is of importance. The tachyarrhythmia, as I mentioned before. The type of surgical procedure, there's a difference, but also concerning the local facts, because of type of operation which has been done in Europe. Senning procedure has more often done, so it's better. In North America, the mustard patients are a little bit better than the Senning patients. And RV dysfunction also is a factor which is an impact of mortality. QRS duration becomes, QRS complex becomes wider within age, which is a sign according to RV volume and for RV growth or RV dilation with the time as a marker of RV insufficiency. The ventricular function, the lines here are, each line is a patient. As you see, within 10 years, for most of the patients, ventricular function gets worse within time. And also, exercise capacity within time gets lower, what we all know from our patients. For the arterial switch patients, some of this data we have already heard yesterday, is also that complex TGA with VSD or pulmonary stenosis is worse concerning the outcome. And facts concerning also survival and outcome is the gender, preoperative instability and age at operation, pressure in left or right ventricle, and concerning the coronary pattern or surgical technique of reimplantation. As survival is good for the arterial switch, we see problems within reinterventions. Patients have pulmonary stenosis or coronary problems, so that a lot of the surviving patients still have problems which have to be treated. And what we see here is that pulmonary flow within time decreases as a sign for pulmonary stenosis. And this we have already seen yesterday. There's a significance rate in severe or moderate aortic insufficiency and aortic root dilation within time after operation. This survival, if we compare the two groups of operation, the atrial against the arterial switch, you see that mortality in the early years of operation has been high for the arterial switch, but then there's a stable state for the atrial switch. Survival is bad in the late years, and for the reintervention there's a significant number of arterial switch patients, but the atrial switch patients are worse than the arterial switch patients. And here's one. This is the study of the Munich Center. We saw this picture before from Alfred Hager, but concerning here the worse outcome of the mustard patients may be due to the fact that they have been operated earlier than the Senning patients, but they are worse than the arterial switch patients. But what here is interesting is that freedom from reoperation, the Senning patients do better than the arterial switch patients. This shows ventricular dysfunction. As we know, for the arterial switch patients, this is not a relevant problem. And also AV regurgitation. And this I showed you before, the loss of sinus rhythm. Almost all of the atrial switch patients have lost their sinus rhythm within time after operation, but also a significant number of arterial switch patients have a sick sinus syndrome. But these patients do not so often need a pacemaker implantation, and as we know, a lot of them need this due to the operation procedure or due to anatomic reasons. Oh, sorry. Right bundle branch block as a marker for heart insufficiency or late complications or late sudden death. We see that this is also in both groups, but mostly this is not shown here in the patients which have had complex TGA with a ventricular septal defect which has been operated, and perhaps this is due to the operation procedure. Concerning medical therapy, we see that most of the transpositions after atrial switch operation need medical therapy. Concerning heart insufficiency therapy, as here, ACE inhibitor therapy or beta blocker therapy for rhythm disturbances, and this is what we see in our daily practice. But theme of this session is quality of life, and if we ask the patients concerning the quality of life in different categories, then we see that there's no significant reduction in quality of life compared with healthy population, and also between the two groups in some categories. Perhaps this is due to the fact that the patients are used to their heart problems, and that they lead a life which is that they do not do competitive sports as we have seen before, so that they do not miss anything in their daily life. In our own patients, we have 166 patients with a transposition after atrial switch. Of them, 113 are still in our regularly visit in the outpatients clinic. 6 of the patients died, but not in the last 10 years. 1 with a sudden death, 3 associated to the operation because of right ventricular dysfunction, 1 with a cyst or transplant, 1 due to heart insufficiency, and 1 due to pulmonary bleeding. The number of patients after arterial switch operation is lower because at the Charité in GDR the operation atrial switch operation has been performed until the mid of the 1880s, so that also our switch patients are a lot younger, as we see here, than our atrial switch patients, which all have reached now adulthood, and we've followed them about 20 years now. About 20% have a complex transposition with a ventricular septal defect or a pulmonary stenosis. About 70-75% have had atrial septicemia before operation, and they have also, the atrial switch patients have been operated mostly about 1 year of age. Concerning rhythm, we see what I showed you before, that most of the arterial switch patients have sinus rhythm. For the atrial switch patients, we just have 20% of our patients which still have sinus rhythm, and a relevant number which have a pacemaker due to sinus rhythm. 1 of the arterial switch patients has a pacemaker due to an AV block according to the surgery. There are a lot of rhythm disturbances, 24% of atrial tachycardia, with 13 patients which have had ablation, and 3 of the patients had new atrial tachycardia after this, so that they had twice an ablation therapy. Also, there's a relevant number of supraventricular tachycardia and also ventricular tachycardia, and 4 patients have had an AICD. The start of rhythm disturbance is about short time after, about just some years after operation. Ventricular function, we have a lot of patients with AV valve regurgitation, but if we look at severe or moderate AV regurgitation, it's a little bit less. Most of our patients get ACE inhibitor therapy, and also 1/3 gets antiarrhythmic therapy due to rhythm disturbance. And what we see here, this is for the arterial switch operations in the early years. They have problems with postoperative failure of the left ventricle, mostly due to coronary problems, but until now, most patients are doing well. Concerning reoperation, this is a much higher in our patients. Also, what we see is, as the other data from Europe, the mustard patients are doing worse concerning this than the Senning patients. For the switch patients, this is a lot lower, and pulmonary stenosis, this doesn't mean reoperation, but mostly dilatation or stent implantation. And just 1 patient which has had a heart transplant. And also there's a significant number of buffal stenosis and buffal leakage which has to be treated, and a little bit higher here as other data from Europe shows in the mustard patients. Concerning neurologic outcome, we will hear this later, we see a relevant number of neurologic problems due to ischemia, or also a relevant number, which is also described in literature, of psychiatric disorders. And this seems to be a little bit, which is also, according to literature, a little bit better in the patients after arterial switch operation. But, as I noted here, we also have patients after atrial switch operation which are doing very well despite of their cyanosis for 1 year. 14 patients have a university degree of our patients. Concerning late mortality, I told you we haven't lost any patient in the last 10 years. Oh, sorry. The other ones, one just was sudden, the others have had operation concerning heart failure, and the 2 other bleeding, and 1 heart insufficiency, what I mentioned before. But also to mention 6 pregnancies with good maternal and fetal outcome in our patients. So now to conclude, what are the problems of our patients? We have a progressive loss in sinus rhythm, an increase in active arrhythmia, and a decrease in right ventricular function, and a risk of late sudden death. But for most of our patients, this is relevant. They are alive and in a good functional status and can lead a normal, mostly normal life. For the arterial switch patients, there are also described problems, decreased coronary reserve, but they normally have no ischemic symptoms. Also impaired LV contractility, reversible perfusion defects, and warm motion abnormalities in studies, but all patients also were asymptomatic. There are, in the early mortality, the coronary artery pattern-related risks, and also due to surgery, and according to type of surgery, risk of pulmonary stenosis, and later on, the risk of neo-aortic insufficiency and dilation of the aortic root. If we now compare both groups, there's a trend towards a more favorable outcome of the arterial switch group. But however, also the arterial switch patients have a remarkable incidence of problems during their follow-up, and we have to seek for these problems. There's an improvement of a long-term outcome since the time of arterial switch operation, but not in freedom from reoperation. And concerning quality of life, there is no difference between the both groups, and no difference when we ask the patients, or most patients, to a healthy population in some studies. And now, why we talk about this today? This is a young lady which is now on our ward. She is 20 years old, is 23 years after Senning operation, has had non-sustained non-sustained ventricular tachycardia in Holter ECG, and now gets antiarrhythmic therapy, and is pregnant in 13th week. And this now leads to the next speaker. We will try to help her to keep the child, and also to keep her good state and life during this. Okay, thank you.